Happy New Year, everyone, and welcome to our January webinar, Parkinson's Psychosis, Hallucinations and Delusions. I'm Donna Greening, Parkinson Canada's Education and Program Innovation Coordinator. From coast to coast, Parkinson Canada acknowledges the ancestral and unceded territories of Inuit, Métis, and First Nations peoples. To access closed captioning, click on the CC Captions button and then click on Show Subtitle. We are always grateful for the expert speakers who join us to share their knowledge during our webinars. If you have questions about today's topic after the conclusion of this webinar, please contact your healthcare provider or Parkinson Canada's support and information team. There's no need to take any notes during the webinar. We'll be sending everyone a link to the webinar recording along with hyperlinks to resources that are mentioned. If you have questions for our presenters, please type them into the Q&A tab found at the bottom of your webinar window. This will help us monitor them more effectively. The chat window is there for you to say hello or talk amongst yourselves. When the webinar ends, please take a moment to fill out our survey, which we use to evaluate our programming, ensuring that we deliver content that's relevant to the Parkinson's community. Now, let's get started. Nini Huang lives in Toronto, Ontario. She retired early in her career to be a stay-at-home mom, a decision that she found deeply rewarding. As her children grew older, both of her parents began experiencing health issues, prompting Nini to shift her focus to their care. Both of Nini's parents live with Parkinson's, and her mother experiences episodes of delusions. Nini finds the role of caregiving increasingly challenging, both emotionally and physically, but remains committed to caring for her parents to the best of her ability. Welcome, Nini.
Thank you very much, Donna, for the introduction. As a primary caregiver to my parents, who both live with Parkinson's, I'm honored to be invited by Parkinson Canada, to share my personal experience in managing Parkinson's psychosis. My beautiful mom was first diagnosed with Parkinson's in 2019, less than a year after courageously and successfully beating cancer. Almost exactly 2 years after her Parkinson's diagnosis, my family was surprised and even shocked when my dad was also diagnosed with the same disease. For my mom's Parkinson's journey, it started off with complaints about feeling imbalanced. Over time, additional symptoms emerged and intensified, such as lethargy, decrease in mobility, and higher anxiety, to name a few. Then surprisingly came the delusions. I've always been a planner, with my favorite motto being, you fail to plan, you plan to fail. While supporting my mom through cancer, I had clear goals on how I want to help my mom fight her battle. I tackled my parents' Parkinson's diagnoses with the same approach, and although it took me a while to realize it, I finally concluded that I needed to shift my perspective. Planning was still important and necessary, but the catchphrase, one day at a time, became a more suitable mantra. I felt like my mom's delusions came out of nowhere. Although looking back, there was a gradual but notable shift in my mom's personality, from nurturing, witty, and engaging to irrational, secretive, and volatile. Delusions can appear in the forms of paranoia, jealousy, false beliefs that are not based on reality, and my mom's delusions made her think that someone she loved was treating her very unfairly. The onset was a very dark and scary period for me, and a subject that I still find difficult to talk about without getting emotional. I'll try not to cry today. Truth be told, I also found it very hard to prepare for this webinar because although I want to share my experience in the hopes of helping others, I also had this overwhelming feeling that I need to protect and respect my mom's privacy. Therefore, I'll try my best to honor my mom while I spill the tea on my personal experience. It began one morning when my mom started exhibiting wildly abnormal behavior. I was told by the neurologist to have a urine test done, and I quickly learned that a urinary tract infection can lead to psychosis. As my mom's behavior grew more erratic while I waited for test results, I reached out to my parents' geriatrician and clinical pharmacist for further advice. I realized then how lucky my parents were to be under the care of a very supportive team of healthcare specialists. They carefully adjusted my mom's medications and antibiotic antibiotics were prescribed when the test did come back positive. My mom's extreme volatility lasted almost 2 weeks, and during this time, all I could do was wait and hope that the medications would help. This is a period where I also took my 1 day at a time approach to the next level, and it became 1 hour at a time. If my mom was not distressed for a brief period, I took that as a win. I immediately began to safety-proof and trigger-proof my mom's environment. I removed all items in the household that could cause her further self-harm. I took away my mom's access to her medications and began storing them in a safety box with a lock. I followed a set schedule for naps, exercise, meals, baths, in the hope of creating a calm environment of predictability and structure. At their retirement home, I discreetly informed my mom's PSWs and nurses that she was not herself due to a UTI and asked them to please be sensitive. Unfamiliar female voices were a trigger for her. Therefore, I turned off their answering machine and even switched the AI voice of their Alexa device from female to male. I spoke to anyone within my mom's earshot very loudly and concisely so that she would not misconstrue things and think I was plotting against her. And I temporarily isolated my parents to remove all external triggers, including ordering room service for their meals. After a few days on antibiotics, my mom's extreme volatility decreased, but her anger and her fixed, inflexible delusions remained in the forefront. Every day was an emotional roller coaster for me. It was heartbreaking to see how distressed my mom was, and at the same time, I felt frustrated, helpless, traumatized, angry, and then guilty for feeling angry. Many times my head felt like exploding, and that's when I knew that I need to remove myself from the room, even for a brief few minutes, to regain my composure. And that's when I would also remind myself to take it 1 day at a time, 1 hour at a time, a few minutes at a time. My dad chose to stay stoic while taking on the brunt of my mom's false beliefs, and it was agonizing for me to see how much it impacted him. He chose to block out my mom's delusions by internalizing them, but soon began struggling with gait disturbances as a new symptom of his Parkinson's. I tried really hard to carve out time to focus on my dad as well, but I was already feeling overwhelmed supporting my mom. Luckily, my dad was the happiest spending time with his grandchildren. Therefore, I enlisted their help to keep him company. Everyone's strategy on how to manage a loved one's dementia and psychosis is unique. Experts advise not to argue over the reality of the situation and to redirect the conversation by changing the topic. But for me, that was easier said than done, mainly because her delusions were directed to a person that I loved too. I couldn't help but try to correct my mom, and not surprisingly, this just left her furious with me, accusing me of taking sides. This period was very frightening for me because I felt very disconnected from my mom. She was like a stranger, and I didn't recognize the glint in her eyes. The glimmer of the mom that I knew finally appeared when I took on a different approach. I stopped arguing over external factors that I could not control, and I focused on rebuilding her trust in me. When my mom brought up her delusions, which was incessant at first, I reminded her how much I loved her. I assured her that I would defend her against any injustices that were real, but that I couldn't do anything for the ones that did not exist. She was dismissive, guarded, and even mean at times, mocking what I was saying. But I continue my affirmations. It's been over 2.5 years since the onset, and although I continue to try to tread very carefully around her delusions, I'm very relieved to say that there are no longer a dominating symptom of her Parkinson's. I credit my mom's team of specialists for this, since they were instrumental in empowering me and giving me the confidence to know that I was on the right track in supporting my mom. To get the right help, I knew that it was imperative to provide full transparency at her doctor's visits and to advocate for my mom when she was unwilling to be forthcoming. At appointments, I often felt like I was walking on eggshells, or better yet, landmines, if I openly discussed my mom's delusions in her presence. Therefore, I would email my concerns to the doctor's team prior to the appointments, and at times even ask to speak to the doctor privately. To avoid further suspicion and paranoia from my mom, I made it seem like it was a doctor that wanted to talk to me separately rather than vice versa. And as for the doctors that my mom was comfortable opening up to, including her psychiatrist, I asked them to help reinforce the cause and effects of her delusions, since any words coming out of the doctor's mouth held 100 times more weight than mine. Being organized was also important in keeping me sane. Since my mom was under an umbrella of specialists, I logged every prescription change on a spreadsheet and provided updates at every appointment. I also typed up detailed summaries after every visit so that I was able to keep track of what was discussed, what changes were implemented, and what my action items were, etc. During my mom's most volatile periods, I kept a diary of how much she slept, what she said, what she did each day to look for patterns. This journey can be extremely isolating for the sufferer because it's often associated with feelings of humiliation and embarrassment, but it can also be isolating for the caregiver too. In addition to seeking help from the specialist, whom I am forever grateful for, I also find solace in other ways that don't require a lot of commitment or time, such as just going for a walk to clear my mind. This journey has taught me that it's okay to lean on others for help, and I participate in support groups such as the ones offered by Parkinson Canada to remind myself that I'm not alone in this experience. I prioritize what I do in my spare time, ensuring that I surround myself with people and things and animals such as my dogs that bring me joy. I rely on my faith to give me the strength to keep going. And although my relationship with my parents no longer feels reciprocal, I grieve this loss, but I also know that my love for them has only grown deeper. In closing, my wish for every person living with Parkinson is to feel that they're being loved and supported throughout this challenging and isolating life. And for the caregivers that walk alongside them, I know firsthand that your care does make an impact on your loved ones. And when it's all said and done, all you can do is take it one day at a time.
Thank you so much, Nini, for your candor and willingness to share about the challenges of coping with your mom's episodes of delusions. It's incredibly heartwarming to see that caring for both of your parents on their Parkinson's journeys is a mission of love for you. And now I'd like to introduce Dr. Alison Dixon. Dr. Dixon is a geriatrician and assistant professor in the Division of Geriatric Medicine at Dalhousie University in Halifax. Originally from Cape Breton, she completed medical school, internal medicine residency, and subspecialty training in geriatric medicine at Dalhousie University. Before medicine, she was a journalist and worked for the Canadian Broadcasting Corporation. She is the communications skills lead for postgraduate medical education at Dalhousie University. Her clinical focus is movement disorders in older adults, in particular Parkinson's disease. Her passion is a comprehensive patient and family-centered approach to helping older adults live well with Parkinson's and other Parkinsonian syndromes at every age and stage. Welcome, Dr. Dixon.
Thank you so much for having me, and thank you to Nini for sharing your story. That it was beautiful and wonderful to hear. I'm just going to share my screen so we can start the presentation here. There we go. All right. Is that okay? Can everybody see the screen, Donna? Looks okay? All right, here we go. So I have no conflicts of interest or disclosures prior to giving this talk, and I really, really appreciate you having me here today to talk about hallucinations and delusions in Parkinson's disease. I'm hopeful what we can talk about today is to try to appreciate the spectrum of non-motor or non-movement symptoms in Parkinson's disease. We'll talk about what are hallucinations, what are delusions, what does that look like? What are the possible triggers for them? How do we treat it? And then we'll talk about some communication strategies for care partners, because that can be really, really a shock when it happens to people you love. And I loved Nini's strategies as well. And one day at a time is a great approach. So everyone here knows that Parkinson's disease is characterized by these signs and symptoms of slowness or bradykinesia, stiffness or rigidity, and tremor for some people. And they may have balance problems or postural instability. So that's something everyone here knows. But Parkinson's is so much more than a movement problem. There's so much more to living with Parkinson's disease. And just to start thinking about the non-motor features of Parkinson's, which I'm sure many people on the webinar today have experienced, and this is just some, this is not everything, but I always tell my patients that Parkinson's affects you from head to toe. So there's a loss of smell, constipation, bladder changes, orthostatic hypotension, which means a drop in blood pressure when people stand up, mood changes, so anxiety, depression, memory and thinking changes, hallucinations and delusions, which we'll go into today, the daytime fatigue, REM sleep behavior disorder. So that's people who are enacting dreams at night, speech changes, swallowing changes, drooling, just to name a few. So to think of that non-motor spectrum. And I bring up this slide only to show you that the blue symptoms on top are these movement symptoms that we talk about, slowness, stiffness, and/or tremor. But in the green below, this shows you just how the timeline of the non-motor symptoms starts. So even before people have the diagnosis of Parkinson's disease, or even begin to develop stiffness and slowness, most people, maybe even for decades, have lost their sense of smell, or have developed constipation, or have had trouble with depression or anxiety, or that dream enactment, that REM sleep disorder. So just to show you that the non-motor symptoms are there sometimes for long periods before we even see the clinical diagnosis of Parkinson's disease. And I'm not the first person to use this comparison. A lot of us talk about this when we speak about Parkinson's, is thinking of it as an iceberg. So the movement symptoms are what we see on the top of the iceberg. There's your slowness, your stiffness, your tremor, the balance difficulty or changes in your walking. But there's so much more below the surface with Parkinson's disease that people don't see. And this is just, again, some of those non-motor symptoms, but the speech, the swallowing, the pain, the sleep, the mood, the anxiety, memory and thinking changes, sexual function changes, changing in how we sweat and regulate temperature. All of these changes are going on below the surface, and not everybody thinks about that. So I think that's important. And when we talk about hallucinations and delusions today, they are a non-motor symptom that we need to think about in the same way we ask about changes in your bowels or bladder or how your sleep is. That's the way we think of these symptoms. So hallucinations, as Nini was talking about as well, delusions we'll get into too. A hallucination means that you're experiencing something that others are not. And that may be seeing something, hearing something, smelling, tasting, or feeling something that's not there. Delusions, like Nini's mother was having, is a false thought, worry, or belief that you believe to be true, and it feels very, very real, but it isn't. And when people experience hallucinations and/or delusions, they don't always have to come together. We talk about that as Parkinson's disease psychosis. And this can happen at any stage of disease, although it is more common in the later stages, but honestly can happen at any stage, even in earlier stages of disease. When it does happen early on, it may be related to a medication change you've had, or if you've had an increase in your dopaminergic medication. And when we talk about what causes it, it's not an easy answer. There are complex brain changes that we know about. There's these little things called Lewy bodies that deposit into cells that can cause changes. There's neurotransmitter changes, not just dopamine, but in chemicals like serotonin and acetylcholine that our brain uses for signaling and communication. There's changes in visual processing. And sometimes it can be triggered by higher doses of medications, but that's not the only cause. So there's a lot of complex changes that happen that enable people with Parkinson's to start developing these types of symptoms. And we'll talk about a little bit of these risk factors, but I also wanted to say, and we'll talk about how common it is, but not everybody will experience this. So if you see yourself in one of these things, maybe a woman who has a loss of sense of smell and a lot of sleepiness in the day, it doesn't mean for sure that you will develop hallucinations or delusions. But we know in the literature that some of these risk factors may make it a little bit more likely. So people who are older, people who are women, who have a phenotype of Parkinson's that's more related to gait changes or balance difficulty, people who have active depression, people who have cognitive impairment, so memory and thinking changes is a bigger risk factor for developing hallucinations or delusions. REM sleep behavior, so that dream enactment at night. So these are some of the risk factors that just raises our possibility that the risk is there to develop hallucinations and delusions in Parkinson's. And it's a common experience for people living with Parkinson's. The literature shows that about 50% of people living with Parkinson's will experience hallucinations or delusions at some point in their journey with Parkinson's disease. So if this has happened to you, we're talking about specific examples today that come up in this presentation and you identify with them, you are not alone. This is a very, very common problem for people living with Parkinson's. And I really want to reinforce that we need to think of it about, and just like we think about any other non-motor symptoms. So thinking of that iceberg below the water, hallucinations and delusions are part of that. So just the same way that we think about our bowel changes or difficulty sleeping, we need to think about hallucinations and delusions. But it's really, really hard to talk about. As you can imagine, there's shame and embarrassment when these symptoms develop. People just don't, oh my gosh, how am I going to tell my loved ones or bring it up that I'm experiencing this? It can be really embarrassing. People have told me I felt like I was going crazy and maybe this wasn't normal. And it's not often brought up at medical appointments unless we ask about it directly. So when we look at hallucinations, visual hallucinations are the most common form of hallucination that we see in Parkinson's disease. Early on, people may have what we describe as minor hallucinations. So two good examples of that, and I'll get into a few others. One is a hallucination of passage. And so someone might say, I was sitting in the living room and out of my peripheral vision in the corner of my eye, I saw this shadowy shape go by. Didn't really look like a person, wasn't fully formed. I looked and no one was there. So this kind of something goes by you in the periphery, you look, and it wasn't there. Was it a mouse that ran by the floor? Not there. That's a passage hallucination, and that's something we call a minor hallucination. There's also something people would describe as a presence hallucination, so a sense of someone's presence around you. People might describe that I feel like someone's standing in the room or standing behind me, but I looked and no one was there. That's another type of minor hallucination. There's also illusions and misperceptions. So things might resemble something else. A speck of dirt on the floor or on the table might look like a bug if you look at it quickly. Or perhaps in your bedroom, you have a heap of clothes on the chair. And when you look, it looks like a dog or a cat sleeping there until you blink and turn on the lights and realize it's clothes. Some people might say that things like rugs on the floor look like a big hole that just dips out of the floor, or lines on the carpet appear to be moving, so a misperception of a visual cue. And then as visual hallucinations progress, for some people, they start to become more vivid, more detailed, more formed. So seeing people, animals, children, those are common themes that people would see. And an example might be looking outside the window and you see kids playing in the yard, even though you know there's no kids out there. And it may appear like normal people or children or animals. And for some people, it can be more of a distorted image where people might see people who are tall and have big heads, or tiny people that are out in the yard. It might look a little different than usual, and that can be really distressing for some people. When we talk about insight refers to someone's understanding of whether what they're experiencing is real or not. Often early on, people will say, I saw a cat in the kitchen right under the table. I know it's not there. I know we don't have a cat, but I saw a cat in the kitchen. So there's recognition that, I know I didn't see that, but when I looked, that's what it looked like. As hallucinations progress, we may lose insight into them. And so something that care partners might notice is that maybe your spouse is setting a plate at the table for someone who's not there at supper time, or somebody might put out a bowl of water for the cat in the kitchen, as opposed to saying, I know the cat's not there, but now they're trying to feed it. So that's a sign that insight may be lost, and they really believe that to be true. And that can happen for a lot of people as time progresses with hallucinations. The other types of hallucinations, so visual are the most common, but some people have auditory hallucinations, so they hear things. Often at night, maybe I hear a party going on in the other room or people walking above me. There's noises that you can't account for. For some people, it might be tactile, feeling something that isn't there, feeling someone touch your arm or touch your back, or olfactory, smelling something that's not there. Although those aren't as common, they certainly can happen in Parkinson's disease. Delusions, like Nini brought up, are those false thoughts, worries, or beliefs that are not based in reality or fact. And some of the examples, there are those persecutory delusions. Someone is trying to harm you. Someone is trying to steal from you. People are lying to me. There's often delusions that maybe someone's living in the house. I can't see them, but I know they're there. People have delusions of infidelity. You know, my partner's been cheating on me, or you go up for groceries and you come back and your spouse says, well, I know where you were, and that's come out of nowhere. There's also delusions that someone close to you may have been replaced by another person. So there's me, Alison, and then there's the other Alison. And that can be really upsetting for people and care partners for people with Parkinson's too. And I just want to bring that one up again because it's something we talk about a lot in my clinic because it can be such a shock. So an example of this happening of a delusion where you're not identifying your spouse, or you think they've been replaced, or there's another one, is something that people might say, I was talking to someone, my partner the other day, and I'm Alison, and they start telling me, yesterday, I went to the grocery store with Alison, and we did this, and they're telling me about what they did with me. That might be a sign that, and that can be a real shock for people, but often that's a sign that there's starting to be a delusional belief or a misidentification there. Sometimes there's duplicates. There was Anne here this morning, and there was the other Anne upstairs. She was mean, didn't like her. There's two of her. That can happen. So there can be multiple people. There can be thoughts that you're not the real you. And there can be times where you might tell stories about your partner to your partner. These can be really distressing. And we'll talk about kind of how to talk about those and what we can do, but it can be a real shock. The first step that I just wanted to reinforce is to tell someone. If you're experiencing this in your journey with Parkinson's, it's so important to let your friends, your family, your medical team know that you've experienced hallucinations or delusions. In general, you're going to need a good review. They're going to talk to you, and I'll talk about what some of the questions we ask about hallucinations and delusions are. A physical exam, a good review of your medications, and it helps determine if it's caused by your Parkinson's or something else. Is it a side effect of a medication, or is it a delirium caused by an acute illness like a UTI? And if visual hallucinations only happen at night, we also need to distinguish those from vivid dreams. So I mentioned that REM sleep disorder that's common for people with Parkinson's, where they have very vivid dreams, dream enactment, yelling, shouting, throwing snowballs at night. If there's hallucinations that start to happen that are only at night, perhaps when you're falling asleep or when you're waking up, some of that can be in the context of a REM sleep disorder. So we often ask, is it happening in the day, the night, or both? My approach generally is, I want to know, is it new? Did it come on suddenly or gradually? And what's changed in someone's recent health? So is there any sign, like Nini brought up, of a UTI or an infection or some acute illness? Has somebody had COVID or pneumonia? Have they had a recent surgery or hospitalization? Sometimes it's even little changes like constipation. The bowels haven't moved in 5 days, and all of a sudden, people are a little more confused than they had been, even dehydration. Always want to know about recent medication changes. So maybe that's that you've had a recent increase in your dopaminergic medications for Parkinson's, Or maybe you've had a new medication added for another reason, or you're taking an over-the-counter medication. We always want a good look at what changed, what new medications there are. And then what's going along with the hallucinations and delusions? Is it associated with any changes in your mood? Are you feeling depressed, or is there anxiety? Or are there changes in memory and thinking? And there does not have to be changes in memory and thinking. You don't need to have those to have hallucinations or delusions, but sometimes they come together. So we really do want to ask people and their care partners about if they've noticed any changes in memory or thinking. The idea, just to reinforce about delirium. So if somebody out of the blue is acutely not themselves, and that might mean suddenly experiencing confusion, hallucinations, paranoid thoughts, we always want to rule out a delirium. And that is an acute change in thinking that's caused by something wrong, usually a medical illness, maybe a medication. Delirium tends to fluctuate, and often people have trouble paying attention or concentrating. They may have a change in their sleep-wake cycle where people are up all night and then sleeping in the day. Often it's associated with a change in our level of consciousness. So maybe people are sleeping more than usual, and then when they're awake, they're much more confused. Or maybe people can't sleep and they're feeling agitated and restless and just, can't settle their bodies. You might see some of those changes. If something comes on suddenly like that, that's to me, that's an emergency. That's when you want to let your care team know, and you need a good medical workup, because that can be the sign of something wrong. And if it's a delirium, we treat the underlying cause. We treat the UTI. We get the bowels moving if there's constipation. If it's related to medication, so for some people, if we've just increased your dopaminergics, maybe we have to go back down a little bit to the previous dose. And if the next, I think, important thing to talk about is, does it bother you? So if it's something that came on very gradually, perhaps you started to have those types of minor hallucinations over the last few months, and then just the other night you thought you caught sight of a small animal in the bedroom and it wasn't distressing to you. Your team still needs to know about that, so we should still talk about that. But if it's not distressing, we may not treat that. So there are medications that we might offer for distressing hallucinations or delusions, but some hallucinations and delusions aren't distressing and don't require treatment, but it needs a lot of education for the person living with them and for the people around them. If it's due to a medication, we may look at weaning that medication, and then we'll talk a little bit about the other medications that we add for treatment. A lot of people ask, if I've experienced a hallucination or a delusion, do I need to wean off some of my Parkinson medication? And, I hope, and I'm sure everyone here knows, because you're all experts in Parkinson's and your own experience with Parkinson's in your life, but we never stop or wean Parkinson's meds without speaking with the care team. And for most people, we may not need to change the medications. And for other people, we need to slowly reduce perhaps that overall dopamine burden. So if you've been on a series of medications for the last 20 years, there may be time that we need a good overview, and some of those might not be needed anymore. And we can look at lowering some of the overall doses. But those changes would be made slowly and always in conjunction with your Parkinson's team, because we'd have to monitor for any changes in your motor function and your movement as well. And because it's not always Parkinson's medication. Some people have been started on, maybe it's a new medication for their bladder or for pain, or a sedative medication for sleep, and all of a sudden hallucinations pop up. So your team will want to know everything you're taking, including over-the-counter medications. Gravol for geriatricians is always a big one because it's quite sedating and can cause confusion. But it's just to show the importance of sharing with your team, if this has come out of the blue, everything you're taking, not just your prescription medications, so we can try to get to the bottom of things. And then this idea of what do we do? So if we've ruled out any underlying contributing causes and there's not a delirium, it's not related to any recent changes in your medications, they've come on very gradually and snuck in there, are they distressing to you? Because that's going to tell us about what we need to do for the next steps. So sometimes, especially minor hallucinations. So those illusions where my coat hanging on the door might look like a person when I look quickly, or the heap of clothes, like I mentioned, on a chair that looks like an animal, that may not be distressing at all. But for some people, the hallucinations and delusions can really affect quality of life. They can be really worrisome and they can be distressing. And that's where we talk about medications that we may need to add to help. And that's where it also is important, like I mentioned before, to look for any changes in memory and thinking, because that also helps with medication options for treatment. And for care partners, this whole experience of hallucinations and delusions can be really, really unsettling and scary, especially, if sometimes you're the person they love, you're the person who's there the most, they're seeing the most, and maybe the target of some of those delusional thoughts and worries and suspicions. It can be a very hard thing. And hearing your spouse all of a sudden say, "Can you ask the people in the kitchen to leave?" when there's no one else in there, can be a shock. The tendency for a lot of people is to want to correct that and say, no, 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 there's no one there. That's not real. Don't worry about that. That's not real. That's not happening. I don't see them. There's nobody there. For some people, that's okay. So there are some people who early on, especially if you have insight and you say, I just looked out and there are 4 people who look like they're working on my car in the backyard. I know they're not there. Then your spouse or your friend might say, no, I don't see them either. They're not there. And you go, okay, I didn't think so. And it's not distressing to you. When you believe that to be true, when people don't have insight into that and really believe that this is happening, correcting people can add to the distress. If you are seeing people in your yard out and about around your car, and it is worrying you, and all someone is telling you is, no, they're not, I don't see them, that's not real, it can add to shame, it can add to anxiety, it can add to distress. And so often what I'll tell people is, don't correct. So we use, and Nini referred to this, which was wonderful too, a kind of connect and redirect strategy. So if someone believes this to be true and it's really distressing to them, you connect and you validate what they're experiencing and what the emotion is. I'll give you an example of what that would be like. So if someone tells you, there were people in my bedroom last night, they were having a party, there was probably 5 of them, they wouldn't leave, I couldn't go to sleep, and they believe that to be true, it's not going to help for you to say that wasn't real. That's what they experienced. That was distressing. And we can only imagine what that would feel like. I would say something like, that must have been awful. That must have been so scary. I'm glad they're gone now. So you've connected, you've validated the emotion. And then you can say, let's go have some lunch. Or do you want to go for a walk? Let's go for a drive this afternoon. If someone's seeing children in the living room and they're frustrated because they won't leave, they're worried, why are they there? There's 10 kids, they're milling about, I don't know who they belong to. You could say, I'm going to tell them to go now. I'll tell them to leave. Let's go in another room because I was going to make lunch anyway. Let's go have some lunch. So it's a connection to what somebody's experiencing, trying to resist the correction tendency that we all have, and a redirect to something just to get your mind off of it. If you don't know what to say, because there's not always the right thing to say, I think just listening is the answer. If you're lost for words, just listening, tell me about that. What was that like? Thank you for sharing that with me. I really appreciate you telling me about that today. Sometimes that's enough. It's just to know that the other person was listening, hearing you, validating you, and that's so important. Other tips for people who are experiencing, this is particularly around visual hallucinations. They tend to sneak in when lighting is dim, might come on in the evenings or as it's getting dark. So we'll often tell people, having a night light in the room at night, leaving a light on in the hallway. We try to optimize your senses. So have you had your vision checked recently? If you're hearing auditory hallucinations, often it's good to at least go get your hearing checked as well. So trying to optimize your senses. And then the routine of, trying to get a good sleep, ensuring your bowels are moving, you're eating and drinking, you're taking your medication on time. That routine is really, really important. When we need to look at medication treatment for distressing hallucinations or delusions, there's a few things we try. If there's changes in memory and thinking, so if people are experiencing those cognitive changes that you hear about, and they're experiencing hallucinations and delusions, we may think about adding a medication called a cholinesterase inhibitor. And those would be medications like donepezil or rivastigmine. And those medications, they won't get rid of hallucinations or delusions, but they can reduce how frequent they are. They can reduce how intense they are, how distressing they are. The other medication category that we use would be antipsychotic medications. There's many antipsychotic medications that aren't safe for people with Parkinson's disease because it blocks dopamine in the brain. But there are just a couple that are, which would be quetiapine and clozapine. These have to be used in conjunction with your team, need monitoring, but these are also medications if your hallucinations or delusions are persistent and distressing and impacting your quality of life, there are options and to talk about things with your care team. This is just to show you, and you've probably already seen this, but from Parkinson Canada, I helped develop a handout on hallucinations and delusions in Parkinson's disease. And it might be nice as well to give to members of your family or friends saying, hey, this is what I'm going through, and they can read more about it because people are shocked to find out how common this is. 50% of people living with Parkinson's will experience this at some point. So sometimes it might be information for you, or it might be your family saying, look, this is what I'm going through. It's a common problem. Here's more information about it. And you can get that on Parkinson Canada website. There's also in the Every Victory Counts book, which I'm sure everyone's read, it's incredible, also has a section on Parkinson's psychosis. And this is my little plug as a geriatrician who cares for people with Parkinson's disease. This is the geriatric medicine approach. We do the 5 M's. So we try to approach every assessment looking at mobility, mind, whether that's mood, cognition, medications, people's multi-complexity, and then what matters most to them. And what I try to tell people and encourage people who are living with Parkinson's is to make sure, and I hope that all your care teams ask about this, but make sure that the people caring for your Parkinson's know what matters most to you. So if hallucinations and delusions have developed, and this has been worrisome to you, if you're wondering how to talk about it or what can be done, make sure that that's brought up at your next appointment. You know, if you came into an appointment and we focused on your tremor, but what I didn't realize is what matters most to you is the fact that there's been some drooling in the last few months. And it's hard to go out to eat with people when you're embarrassed about drooling, or that you've been really limited by how tired you are in the day and needing to have a nap when you've never napped in your life before. We need to know about those things so there's not a mismatch in what's meaningful for you. So this is just my plug as a geriatrician to make sure that everyone around you who's helping care for your Parkinson's knows what matters most. The take-home points today, and then we'll have lots of time for questions, but hallucinations and delusions are common in Parkinson's disease. At least 50% of people will experience them at some point. And I should say that because you've experienced it doesn't mean that you will forever. So everyone's unique with Parkinson's, as you know. Everyone's journey is unique. Some people will experience them and they will go away. Some people will have them and they'll be a bit persistent and they may be there for a long time. And for some people, they do get worse. But just because you've experienced it doesn't mean it's there forever, but it's very common. We need to talk about it. This is an important non-motor symptom. Think of that iceberg. I want to know all of the stuff that's below the surface. So it's just as important as talking about our bowels and our bladder and our blood pressure. It's just as important to talk about hallucinations and delusions. And your Parkinson's team needs to know, especially to me, if it happens suddenly, if it was an acute change and the people around you said, oh my gosh, yesterday you were fine and today this is not Dave, then your team needs to know, because that could be a delirium, which is an acute change that can cause confusion, hallucinations, psychosis because of a medical illness, and you'll need a medical review. And if the underlying triggers have been addressed, that's when we look at evaluating your Parkinson's medications. We evaluate whether we need to add another medication. For care partners, I hope that you have a place that you can talk about this too, because it's a hugely emotional experience. There's sadness, there's grief, there's sometimes just frustration. I'm fed up with this. I don't know how to deal. And these are all normal emotions. And so you need a place to talk about that as well. And if you don't know what to say, just listen and be supportive. And you don't need to correct people. It's not one of those things where if somebody believes that they're seeing something, you don't have to say it's not there. You can say, okay, I'll get rid of that cat. I just left the back door open. Let's go have some lunch. And the last point is just that people living with Parkinson's psychosis, so living with hallucinations or delusions, can live well with Parkinson's. But the first step is talking about it. The people around you need to know. Thank you very much.
Thank you so much, Dr. Dixon. You provided us with amazing information that can help both care partners and people with Parkinson's have informed conversations with their care providers about Parkinson's psychosis. We are going to jump now to questions that have been submitted, and we have a lot, so we aren't going to be able to get to them all, but we'll do our best. To start, we've had someone ask about Parkinson Canada's collection of clinical research regarding services and supports for the body, spirit, and mind of those with Parkinson's or caregivers. If anyone has questions about research, they can contact Parkinson Canada at 1-800-565-3000, and that will be in our follow-up email, and ask to be connected to the research team, and they can answer all of your questions. So let's move on to the questions now. So the first couple of questions are going to be about symptoms. Dr.
Sure.
Dixon, how can you recognize early stages of Parkinson's psychosis? Like, how can loved ones tell if it's either misremembering or memory loss versus delusions in the early stages, or is it quite clear?
That's a very, very good question because it's sometimes not very clear. So because of that reluctance to talk about it, because of the feelings of stigma around it and shame and embarrassment and, oh my gosh, am I going crazy? I can't tell people about this. It sometimes can be very hard to detect. I really liked what Nini brought up because sometimes it is that shift in personality that you described where you notice, geez, they just don't seem themselves. It just seems like maybe they're on edge or having some more anxiety or seeming unsettled. It may be that you detect a change in personality, or in the case where somebody's had delusional thoughts, some secretive behavior. You know, why is somebody hiding their watch in the, back of our closet? Like, this is just a very odd behavior. So it may be that you notice changes in personality and behavior. And then for visual hallucinations too, some people, until we ask about it, partners who live with someone with Parkinson's will be like, I had no idea that was happening. Sometimes you can tell, but that somebody might be looking at something and then look back, that's not there. Or maybe it's the setting a place at the table, or, feeding the animal, or putting something out in the backyard, a bowl of water for the animals you've seen there. But sometimes it is just very sneaky and hard to detect.
Thank you. Follow-up question. Does the person who's experiencing the Parkinson's related psychosis recognize what's happening to them?
Not always. Early on, often people do have insight and they might say, I've seen this, I know it's not there, but it looks really real to me, but there is that insight. As time progresses, often people may lose that insight, and then they will speak about something as if it is, because it is very real to them. So there are people who experience this who say, I know it's not real, but this is what I see, or this is what I'm hearing. And then there are people who have lost insight into that and believe it to be true. In delusional thoughts, they're a little different because often the insight's not there. The belief just is so real. It's not like seeing a shadow and you look and nothing's there. It's that firm belief that someone has stolen something or out to get you, or there's not a lot of insight there because people aren't aware that it's not a truth. It feels like a truth.
Okay, great. Thank you. Nini, the next question is for you, so we want to make sure you're unmuted. Great. Okay, the question someone asked is, have you found that your mom's delusional behaviors have increased with her disease progression?
My answer would be yes and no, because my mom is considered atypical Parkinson's. So she was only diagnosed a little bit over 5 years ago, but her progression moved fairly fast compared to, I guess, what would be typical. So I would say that basically my mom, we would visit the doctor every 3 months, the neurologist, and then my mom kept on complaining about her lack of mobility. So we would keep increasing her dosage of her levodopa. And it got to a point where she became very anxious, agitated. And from my experience and what the doctor has reminded me over and over, it's a fine balance between whether you want to increase the levodopa, but then it can also have side effects of anxiety. So what I found was that with my mom, at the peak of her delusions, she was on I think 10 tablets, like 9 regular tablets of levodopa with one, the evening one for sleep. So we immediately started cutting down her levodopa, well, slowly progress with a progression. And then also the doctor prescribed an antipsychosis drug to help her initially. It was a very small dosage, but I found that it helped. So now with her progression, her delusions have lessened. So therefore, I think it's not necessarily related to the longer that you have Parkinson's, your delusions or your psychosis gets stronger. Like, I think it's a combination of the fact that we managed her levodopa a little bit better, and also with the help of her antidepressants as well as her antipsychotic drug.
Great, thank you. Now, several people have asked, so I'm kind of combining their questions, that they see or hear things that aren't really there when they're in bed about to fall asleep. Is that considered a hallucination that should be treated, or is it more something that happens in that transitional state between being awake and asleep?
That's
Dr. Dixon?
Yeah, that's a very good question. I'm asked that a lot in clinic, actually. And we know that people even without Parkinson's can experience those sleep-related hallucinations. And maybe some people here who don't have Parkinson's as well may have experienced that sometimes when you're in that dreamlike state about to fall asleep or when you first wake up. But we know those sleep-related hallucinations are also more common in Parkinson's disease. Often, if that's the only time where the hallucinations happen, and I often try to tease out, is it truly when you're in bed ready to fall asleep? Because for some people, it's actually because it's the evening and they're going in a bedroom where it's darker and it's not bright. And when I go in the bedroom and I'm getting ready to go to bed at night, that's when I'm seeing, movement in the periphery. And that wouldn't be really a sleep-related hallucination. That's just a visual hallucination that's happening at night. When it's truly in those moments of what they call hypnagogic, going to sleep, or hypnopompic, when you wake up hallucination, for a lot of people, that might be in the context of their REM sleep disorder. So those vivid dreams, that dream enactment. And we might end up trying to treat that REM sleep disorder to see if we can lessen the intensity and frequency of that. And it can improve the sleep-related hallucinations. So those sleep-related hallucinations are more tied to REM sleep disorder, although more common in Parkinson's and certainly kind of part of that spectrum of hallucinations in Parkinson's disease. Oh, sorry, you're just muted there, Donna.
Sorry about that. There was a question submitted, a couple actually, about night terrors, that it can be very scary and disruptive.
Yeah.
So is there something that they can do to help reduce those night terrors?
That's because the existence of REM sleep disorder is so common in people living with Parkinson's, also common in people living with dementia with Lewy bodies, also common for people living with multiple systems atrophy. It's something that really important to talk to your care team about, because there are medications that can be helpful in just general things. If you're sleeping with a bed partner who's acting out dreams at night, sometimes it's significant enough that you have to split up the beds or putting a ridge of pillows between. Some people have to actually change the sleeping situation, making sure there's nothing you can hit at night. Some people have fallen out of bed or might hit a nightstand because it can be quite significant, the acting out. Often your care team will have some very good suggestions, but often even people will take melatonin at night to help with sleep, which is over the counter and something quite easy to try while you're waiting to talk with your Parkinson's team about other prescribed therapies that can help, but there are treatments that help treat REM sleep disorder. So if there's a lot of big dream enactment, it's disruptive for, you feel worn out if you were really going all night and not having a restful sleep, and it can be exhausting for the people trying to share a bed with that person too. So it's a really important thing to talk about with your care team, and there are options to help.
Okay, and a follow-up to that, would sleepwalking fall into that category as well? Because someone has asked that if their partner is sleepwalking, what should they do? Like, should they wake them up to get them back to bed, and is that part of the whole REM sleep disruption, or is that separate?
But that's a really interesting question, because usually sleepwalking is a non-REM sleep disorder. So it usually doesn't happen in REM sleep, but there can be kind of an overlap for certain people. Not as common as the usual hollering, shouting, punching or kicking, that kind of dream enactment. It's not as common to have people get up and go and sleepwalk, but it certainly can happen. Often in those cases, we'd make a referral to a sleep medicine specialist and have a sleep study to know what's going on, because that helps us guide treatment. So sleepwalking certainly happens outside of REM sleep and can be a separate thing, but there is an overlap where people with Parkinson's can have sleepwalking. I know there used to be a thought of don't wake people up. The general thinking is just guiding people back to bed if you can, without, it's safe to wake them. It doesn't cause any harm, but you can imagine if someone woke you up in the kitchen when you went to bed in your bedroom, it can just be a little shocking. So if you can just help guide somebody back to bed if they walked out of bed, that probably would be the best case scenario, but it's not harmful to wake somebody up who's sleepwalking. It can just be a bit confusing.
Okay, great. Here's a question for Nini. Someone is asking how you handle the anger and agitation that often goes along with the delusions.
I think the main thing is not to take it personally. And with me, I don't live with my parents, so I'm not with them 24 hours. So I can only imagine if you actually lived in the same household with them, how exhausting and how overwhelming it might feel. But for me, when I was there, my mom used every opportunity to then grab me and then start talking about her delusions. So basically all I could do was let her vent, first of all, because she would get angry if I didn't let her vent or dismiss her, but just a lot of sympathy and a lot of love. I just basically kind of, the term killing somebody with kindness. I kind of just overwhelmed her with my love. And I know it's easier said than done because I don't actually live with her full time, but I just used a lot of love, a lot of sympathy and affirmations for her, saying, Mom, like I can only understand how this frustrates you, but I love you and I'm here for you. And I found that actually another tip that was helpful was I kind of flipped it around, because I did explain to her that her beliefs were because of her delusions. And I used an example because my dad also had Parkinson's. I said, you have to be understanding, because what happens if dad had delusions and he was saying mean things to you as well? So it kind of made her kind of think, okay, because I would say, like, if he did that to you, I wouldn't let that happen because I would protect you. So just a lot of sympathy and love was basically the way that I found that I got to my mom.
Great advice. Dr. Dixon, a question has been submitted about drugs, good and bad. Can drugs like rivastigmine, Vyalev, or medical cannabis cause hallucinations or make them worse?
There are a lot of medications that could contribute to hallucinations. Rivastigmine is actually one of the medications that we use for treating Parkinson's dementia, and it can be, most of the evidence is that it's quite helpful to reduce hallucinations and delusions. So it's actually quite a helpful medication. Rare case reports of people having confusion or hallucinations or delusions from rivastigmine. So sometimes that's quite a helpful medication. Vyalev, and if people don't know, which is the subcutaneous levodopa carbidopa, levodopa carbidopa, has because as you can imagine, it's delivering levodopa directly into your system, not going through the GI tract, has been associated with higher risk of hallucinations as opposed to oral levodopa therapies. And that's why your team will work really carefully to find the dose that's right for you, because it's that low continuous dosing as opposed to taking oral medications throughout the day. So that's something that your team would talk to you about with Vyalev and what that would look like. Medical cannabis, I think, was your last medication that you asked about. I get asked that a lot, and there's not a lot of evidence for using cannabis in Parkinson's disease, but I'll tell you, there's a lot of interest that people will read about it online and ask about it. And I don't have any literature to say if it's helpful in symptoms of Parkinson's or not. I will tell you that, you know, when people use certain supplements and oils and gummies, that the THC is quite worrisome because that's the more cognitive affecting substance as opposed to the cannabinoid. So if there's anything with THC in it, the risk is certainly higher of confusion, hallucinations, and those type of symptoms, as opposed to the ones where there's not that THC content. But I don't have any evidence to tell that it's going to be helpful for Parkinson's.
Thank you. Someone has asked if there are delusions or hallucinations, would it be advisable to consult a specialized psychiatrist?
It depends, I guess, what's the care team you have for your Parkinson's and what their comfort level is. So most, I would say most neurologists and geriatricians feel very comfortable managing Parkinson's psychosis. There are times when we need, and I have colleagues in geriatric psychiatry here in Halifax that I will say, I need your help with this. This is a very difficult to treat distressing hallucinations or delusions in Parkinson's, and their expertise is incredible. So there are times when we need to have a psychiatrist as part of the team as well. Generally, the starting point is to at least bring it to your care team, see if it's maybe an adjustment in your Parkinson's medications, if there's anything else they can do that would be helpful, and start treatment. But certainly there's possibilities, and especially I find very distressing and intense psychosis is when we may need our colleagues in geriatric psychiatry for their expertise, which is very helpful for this too.
Great, thank you. A quick question for Nini. Someone is asking if both of your parents are in long-term care. It seems like you're there a lot.
I am there a lot, but my parents live in a private retirement residence that's assisted living. So they do have like a PSW on the floor, but I go there probably about 3 or 4 times a week to just to basically nag and annoy them.
That's a kid's job, right? Wonderful. Okay, just a couple more quick questions that I really want to get to. Someone has asked, does medication that's prescribed slow down the symptoms of hallucinations and delusions?
So if we need medication to treat those symptoms, so if there's distressing hallucinations or delusions, what generally they do is they decrease maybe how frequent they are. So maybe it goes from being every day to a few times a week. It can decrease the intensity and then that level of distress that comes with them. So often it doesn't get rid of them altogether. And certainly there are people, though, that through the course will just, boom, all of a sudden that delusional thought is gone, or at the next follow-up, they go, you know what, I haven't had a visual hallucination in 6 months now. So it's not to say that those can't come and go, but the medication is geared towards kind of reducing the overall intensity and how distressing they are, but not to slow it down or get rid of it.
Okay. Second last question is, if someone's parent is now in long-term care and they've lost the ability to walk, can delusions be medicated when they're at that stage of their Parkinson's?
Absolutely. Yeah, there's always different needs at different stages of Parkinson's disease. And Nini brought it up really well too, that kind of balance of what we call the mind and the motor, you know? So sometimes we're really going for higher doses of dopaminergics, trying to optimize motor function. And we might hit a point where it starts to bother sometimes with some of the mind symptoms. So some of those hallucinations or maybe some confusion, and you have to eke back the doses. And sometimes that results in a worsening of mobility. So there's a very fine balance over time. But people who've lost their mobility with Parkinson's and are at an advanced stage of disease, there's so much we can do and so much care we can do at that stage as well. Absolutely, hallucinations and delusions are treated. And I would also want to be very careful that we don't miss delirium, because in people who perhaps can't share exactly how they're feeling as much anymore, maybe their speech is low and dysarthric or hard to make out, maybe there's cognitive impairment or they've developed dementia. You have to be careful. People might not be able to tell you, my bowels haven't moved in a week and I'm actually really uncomfortable, or they've developed a UTI. So being very careful that we look for medical causes or things that might be triggering those types of symptoms. So worsening confusion, hallucinations, or delusions, but absolutely they can be treated. And still, whatever your mobility is, there's always options to help improve quality of life at all those stages.
Super. Thank you. That's all the time we have for questions today. I know that we were asked if a copy of the presentation can be provided. So I will check with Dr. Dixon, and if that can be provided, then we will include a link with the follow-up email that we send. Thank you everyone for submitting such great questions. On behalf of Parkinson Canada and our viewers, thank you, Dr. Dixon and Nini, for joining us today and providing insight into the medical and personal aspects of Parkinson's psychosis. If we didn't get to your question today, or if you'd like to contact Parkinson Canada's support and information team to discuss Parkinson's psychosis or any other topic, their contact information is in the chat window and will also be included in our follow-up email. Watch your email inboxes for that email. It's also going to include a link to a recording of this webinar and any resources mentioned here today. We also invite you to join our next webinar taking place on Wednesday, February 19th from 2 till 3 Eastern, where we'll be exploring how personal, community, and professional connections can help individuals living with Parkinson's and their care partners to still thrive in the face of challenges. Watch your email inboxes for more details and the registration link. And again, when the webinar closes, please take a moment to fill out our short survey. It helps us plan programming that's relevant to you. On behalf of all of us at Parkinson Canada, I'd like to thank you for joining us, and I hope that you enjoy the rest of your day. Take care.